Hi, and welcome to my channel. This is a review of vestibular neuritis for educational purposes. We're going to be focusing on vestibular neuritis, its pathophysiology, several pharmacotherapies, nursing considerations, and patient education. Vestibular neuritis, VN, also known as vestibular neuronitis, is an acute peripheral vestibulopathy. The term vestibular neuritis was coined more recently in light of evidence that vestibular ganglion cells are not inflamed, whereas parts of the vestibular nerve are. VN makes up about 70% of acute vestibular syndrome cases, and its etiology remains unclear. While the exact etiology remains unclear, viral infection of the vestibular nerve is thought to be one of the main causes of vestibular neuritis, along with the ischemia of anterior vestibular artery. Other causes may include immune-related mechanisms, which cause the nerve to become inflamed. Common viruses that may cause infection of the vestibular nerve include upper respiratory infections like influenza, herpes simplex, adenovirus, and Epstein-Barr. Herpes simplex virus type 1 DNA is found in the vestibular ganglia in 2/3 of autopsies, strengthening the evidence that herpes simplex is the most common cause of vestibular nerve viral infection. In ischemia of the anterior vestibular artery, the cascading inflammatory response releases cells that contribute to thrombolysis, ultimately reducing microvascular perfusion. This means that the nerve and its surrounding tissues aren't receiving the oxygen and other nutrients they need to function properly. VN primarily occurs in the superior vestibular nerve rather than the inferior nerve due to anatomical differences. The superior vestibular nerve and its arteriole are within a significantly narrower passages and are 7 times longer than the inferior. Ischemia of the anterior vestibular artery is a less common proposed cause of VN. It's also something that can be caused by VN, as inflammation of the nerve entraps the nerve and its arteriole in its narrow, bony passage. The immunological imbalance between both T helper and suppressor cells is the root of immune-related mechanisms causing VN, which is similarly observed in multiple sclerosis. Severe, acute, and spontaneous vertigo without hearing loss, tinnitus, or stuttering is the hallmark symptom of vestibular neuritis. See that little star? It's the hallmark symptom. Remember that. Other common clinical manifestations include intense dizziness, coordination issues and imbalance, and nystagmus to the opposite side of the affected vestibular nerve. Other symptoms include nausea, vomiting, and difficulty concentrating can be subsequent as a result of these manifestations, most commonly due to the severe vertigo. Clinical manifestations which help diagnose include the abrupt rotational vertigo lasting longer than 24 hours, accompanied by nausea and vomiting in middle-aged adults without cochlear symptoms like hearing loss, tinnitus, and stuttering. When trying to remember all of the diagnostic testing used for VN, we try to use the STANDING acronym, which stands for distinguishing between spontaneous and positional nystagmus, the evaluation of the nystagmus direction, the head impulse test, and the evaluation of equilibrium. It's an acronym that can help us identify VN. Some of the diagnostic tests include head impulse tests by thermal caloric tests, vestibular evoked myogenic potentials or VEMP tests, posturography, rotational tests, and MRI or CT scans. A head impulse test is a bedside test of the higher frequency vestibular ocular reflex, performed by observing corrective eye movements after grasping the patient's head and applying a brief, high acceleration side to side head turn. Corrective rapid eye movements, or saccades, are a sign of decreased vestibular response. This test may appear falsely negative if the vestibular deficits are mild or the observer does not visualize covert saccades, which may warrant a video head impulse test to closely monitor the covert saccades. The bithermal caloric test stimulates the horizontal semicircular canal by alternating heating and cooling of the external auditory canal with air or water. This diagnostic test provides the most consistent and prominent results in VN. To further qualify and quantify vestibular deficits, vestibular evoked myogenic potentials, or VEMPs, can be used to elicit vestibular-dependent reflexes by delivering short bursts of sound through the skull via headphones or vibrations. Posturography can quantify the contributions of the senses to postural control in a standing position and provide insight into the presence of postural instability. It's also necessary to distinguish VN from other diseases to make a differential diagnosis. A physician may perform additional tests, such as the Dix-Hallpike maneuver, to diagnose benign paroxysmal positional vertigo, for example. Pharmacotherapies. Corticosteroids are used to reduce inflammation of the vestibular nerve to improve VN. However, there is limited significant research, and as a result, this calls for higher quality randomized controlled trials to better evaluate the efficacy of corticosteroids. Corticosteroids are the first line of treatment, and they should be prescribed within 3 days of symptom onset. The most common corticosteroid prescribed for VN is prednisolone. Symptomatic therapy includes second and third line treatments, such as supportive care, vestibular rehabilitation, antiemetics, and vestibular suppressants. Prednisolone is a corticosteroid which binds to glucocorticoid receptors, suppressing pro-inflammatory cytokines and inducing anti-inflammatory proteins. The recommended dose is usually a 50 milligram pill a day for 10 days, initiated within the 3 days of symptom onset. The goals of therapy are to reduce inflammation of the vestibular nerve. Other diseases that prednisolone treats include, but are not limited to, SLE or lupus, asthma, and multiple sclerosis. Meclizine, also known as the brand Antivert, is a histamine H1 receptor agonist, which reduces vestibular excitability. Like other second or third line therapies, it's intended to be a short-term medication to help treat nausea and vomiting caused by VN. It will be initiated after the onset of vertigo and its symptoms, such as nausea and vomiting, as its therapeutic goals include symptom management. Meclizine is also helpful in treating symptoms which are secondary to motion sickness and inner ear issues. Okay, bear with me. This slide goes into a little bit more depth of prednisolone and meclizine. Prednisolone is contraindicated with desmopressin and mifepristone. Interactions can induce side effects such as headache, dizziness, weakness, nausea and vomiting, and hyponatremia. These interactions can worsen VN as well as other comorbidities such as cataracts, congestive heart failure, Cushing's syndrome, diabetes, glaucoma, tuberculosis, myasthenia gravis, mood disturbances such as depression, peptic ulcers, fungal infections, herpes simplex virus eye infection, and kidney disease. Meclizine has more drug interactions, such as with isocarboxazid, potassium chloride, potassium citrate, and tranylcypromine. These are drug therapies that may have the most severe interactions with meclizine. Interactions may cause side effects such as increased sedation, drowsiness, and altered mental status. For breastfeeding, there are limited adult studies for prednisolone to determine infant risk. However, it's been shown to be harmful to the fetus. Therefore, effective birth control should be used when taking prednisolone. There are minimal risks for taking meclizine while breastfeeding, though there are limited adult studies showing risk to the fetus. Due to its effect on alertness, meclizine is not recommended for use with sedating medications or when operating heavy machinery. Dosing considerations for prednisolone include a recommendation of 0.14 milligrams to 2 milligrams per kilogram per day in children, divided over 3 to 4 times a day. Adjustments in prednisolone dosing may be indicated in high-risk geriatric patients with a higher risk of comorbidities affecting the kidneys or bones. Meclizine is not recommended in patients under 12 years old. Meclizine should be cautiously prescribed in geriatric patients due to age-related differences in organ function. Side effects common in the elderly when taking meclizine include confusion, dizziness, and urinary retention, requiring dose adjustments or alternative therapy. Other therapies or non-pharmacological therapies include early rehabilitation. This is key in most, if not all, neuro cases. Early rehab in vestibular neuritis can help restore balance and reduce symptoms. Starting rehabilitation early also reduces risk of the body compensating for vision disturbances. You don't want blurry vision to become your new normal, right? So things like gaze stabilizing exercises and habituation training, which reduce motion-induced dizziness, may help correct these disturbances. It's also important to avoid unnecessary stress on the vestibular nerve. It may not be wise to drive, participate in vigorous exercise, and certainly not going on any roller coasters anytime soon. Lifestyle modifications can include reducing fall risk, gradually returning to normal activities of daily living, and maintaining body strength. Removing objects that may pose tripping hazards, improving lighting, and storing essential items within reach are all ways to reduce fall risk. Getting up too quickly, either from a bed or a chair, can cause orthostatic hypotension. This is when movement depletes blood pressure, causing dizziness. Getting up too quickly, in addition to vestibular neuritis, can increase dizziness, thereby heightening the risk of falls. It's essential for those recovering from VN to take it easy. Returning to activities of daily living and maintaining physical strength go hand in hand. It's important to not be completely sedentary and to continue attempting activities of daily living, such as brushing your teeth, making a quick meal, and bathing to maintain muscle mass and strength. Again, avoid strenuous exercise as overexertion can worsen vestibular neuritis. Anti-inflammatory supplements and nutrition are also options for additional therapy. However, it's important to consult a doctor when using these. In unusual or severe cases, physicians may want to try vagus nerve stimulation or transcranial direct current stimulation to alleviate debilitating, long-lasting symptoms. Surprise! Knowledge check. What is the hallmark sign of vestibular neuritis? Is it A, sudden nausea and vomiting? B, severe acute spontaneous vertigo? C, areflexia? Or D, horizontal torsional nystagmus? I'll give you a moment. Yep, pretty easy. It's B, severe acute spontaneous vertigo. The hallmark for vestibular neuritis is severe acute spontaneous vertigo. Remember, this isn't the common vertigo people experience from riding a roller coaster. This is caused by inflammation of the nerve. Nursing considerations. The nursing assessment should cover when the symptoms first became present and any recent infection history as well. This will help us better understand why they present the way they do and what their treatment may look like. A thorough neuro exam will be necessary to understand their current neurostatus. Checking for nystagmus when looking at the eyes, coordination issues such as ataxia, and hearing disturbances are examples of what to look for in a neuro exam. Nursing diagnoses may include risk for falls, we'll talk more about this on the next slide, risk for injury, anxiety or fear, impaired physical mobility, disturbed sensory perception, and deficient knowledge. Nursing interventions include fall prevention interventions and neuro checks for acute, altered mental status. Fall precautions vary between hospitals, so be sure to check the standard operating procedure. Usually, fall precautions include having the bed at the lowest position, having all personal items within reach as well as a call bell, having fall preventive socks on when out of bed, and the bed alarm on. Avoiding spells of dizziness is important too. Assist with ambulation, educate patients on dangling their legs over the bed for about 30 seconds before climbing out of bed, and monitoring vital signs for hypotension. Frequent neurochecks for these patients can help assess for acute changes in mental status and whether the patient's status is declining or improving or waxing and waning. Surprise again! Knowledge check number 2. Don't worry, it's the last one. All right. What best represents first-line treatment of vestibular neuritis? A, vestibular rehabilitation therapies. B, glucocorticoids. C, corticosteroids. Or D, antiemetics. This one's a little bit harder, I think. And the answer is C, corticosteroids. Prednisolone, in this case an oral corticosteroid which binds to glucocorticoids, is usually given at 50 milligrams for 10 days to reduce inflammation of the nerve. Great job. Patient education. It's important to notify a physician when new, sudden symptoms of VN occur, especially the hallmark symptom of vertigo. Seeking medical attention for proper evaluation and management is essential for a more efficient recovery. Some people may continue to experience lingering symptoms for weeks to months after diagnosis. Although diagnostic tests are necessary to begin an effective treatment course, they can be lengthy and may worsen symptoms temporarily. Educating patients about this process may prepare them and build rapport. Treatment options include anti-inflammatory medications, often covered by insurance, and other medications to treat symptoms, which are often over the counter and more easily accessible to patients. Even if medications are easily accessible, they should still see a physician to understand the risks and benefits of the medication and to learn about the most appropriate dosing based on their age and physiology. If a dose is missed, they should take it as soon as possible and be advised to not double dose, as double dosing can worsen medication side effects. Summary. Vestibular neuritis is thought to be caused by inflammation of the vestibular nerve, with its hallmark symptom being sudden and severe vertigo. Diagnostics include several specific tests, primarily testing for nystagmus and ruling out other nerve disorders. Pharmacotherapies include corticosteroids such as prednisolone and symptom relief therapies such as antiemetics like meclizine. Nursing considerations, they primarily involve the understanding of the onset of symptoms, a thorough neuro exam, and fall precautions. Patient education is valuable, as it is important to seek medical attention as soon as possible to prevent worsening of symptoms or adverse effects. Thank you for watching or listening. Please like this video if you thought it was helpful at all, and let me know what other topics you would like covered. Here are my references. Bye!